And we are going to go ahead and get started. I'm going to cover a few housekeeping things before we get started. I did put in the chat the pre-test, so if you want to go ahead and take that, I will put it in again just in case anybody has joined since then. So go ahead and take the pre-test. And if you could take a moment to just type your name and credentials and where you work or whatever into the chat, just so that we can kind of see who's joined us and keep track of that. We do ask that you, if you want to, have your camera on. However, I know a lot of people are using this as their lunchtime, and so maybe don't want to, so that's okay. I also understand. And please make sure you are muted. That is a biggie because it can be noisy sometimes. If you do want to ask a question, you do have a few options of asking a question. One, just like if you were in a live session, it is okay to just, at a convenient time, ask and just, ask Dr. Underwood a question for some clarification, that piece. You can also type in the chat, and I myself will be monitoring the chat and do that. And then we also will have a question and answer period at the end. So welcome to do that. I did put the pre-test in. At the end of the session, I will put the post-test into the chat, as well as the link for the evaluation. If you do want CMEs for this session, any continuing education, you do have to complete that evaluation. And with that, I am going to turn it over to Dr. Underwood for her to introduce herself and to get us started. So thank you very much.
Thank you so much. So my name is Dr. Amy Underwood. I'm a child and adolescent board certified psychiatrist, and I'm happy to be here today. I actually have some affiliations with North Dakota from when I worked back in 2011 through 2014 at Prairie St. John's in Fargo, North Dakota. So that's how I kind of ended up here with you guys today. But currently doing some telehealth to other areas that are underserved. And so I see a wide variety of patients, but definitely have always had an interest in our autistic populations. And in more time that I've seen patients, I often have noticed some of these other co-occurring things and just wanted to kind of bring it to everyone's attention to sometimes be on the lookout for some of these disorders that are more common in our autistic populations. And let's see what kind of other professionals we have here. So looks like awesome. So we have a student and a therapist and a PhD, a BSN, RN, supervisor, and counseling student. Awesome. Thank you so much for being here and spending your time with us at this Lunch and Learn. So we'll go ahead and get started here. So our objectives are to learn some of the often overlooked comorbidities in patients with autism spectrum disorder, to learn some of the prevalence rates of things like attention deficit hyperactivity disorder, hypermobility syndromes such as Ehlers-Danlos, and ARFID in patients with autism, and to also know about and how to prescribe FDA-approved medications for autism spectrum disorder. And also, I do have no disclosures to report for this presentation. Just to check, are you all still seeing my screen?
Yes, we are.
Okay, I'm seeing the little project echo, so I just wanted to make sure that that was not coming up instead of this. All right. Thank you. And then with the pretest, I thought that this was kind of an interesting first question. We'll definitely go through a little bit of this, but I think many of our providers are familiar with patients who have autism having co-occurring anxiety problems and sometimes some mood issues. So they may be a little bit more surprised to learn some of the prevalence rates of other things. And we'll get started with the DSM criteria. So as in my training, we actually had a different subset of criteria. So with the new DSM-5, they did come out with talking about both the autism with and without some accompanying intellectual impairments, as well as with and without accompanying language impairments. So with autism, there is a persistent deficit in problems with social communication, social interactions, often interfering in their ability to kind of make friends, to understand social cueing, and to understand how to engage with others in that way. There may also be deficits in their nonverbal communication. So they may also have some things such as stereotypic behaviors, or often some kind of complex motor tics or motor habits that may also occur. And they also may have difficulties in developing and maintaining certain relationships, whether that be with adults, children, or with teachers. They also may have restrictive or repetitive patterns of behavior, interests, or activities. A lot of us are very familiar with some popular things that they may fixate on, often things like Minecraft or Pokemon cards. They may love certain television shows or video games, and they may talk about those things very easily. But when it comes to other topics, they may struggle to kind of share that back and forth in communication with others. And then, as many people are on social media here recently, there has been a rise of some talk of a diagnosis called ADHD. And that was something that I first kind of saw talked about in the neurodivergent community on TikTok. So a lot of patients who have autism may also have co-occurring ADHD. And to kind of group that together or lump that together, they came up with their own kind of self-diagnostic group called ADHD. So this is definitely not something that you would see in the DSM as of yet. But it is important for us to also kind of be aware of what terminology some patients may use out in the clinical and non-clinical communities. They feel that having this diagnosis helps them understand each other better in terms of recognizing that they may have both symptoms and patterns of behavior related to autism, as well as difficulties with impulsivity, hyperactivity, and attention. And the prevalence rate of ADHD in patients with autism is actually 50% or even a little bit higher in some studies. So that's very important for us to really screen for our patients to make sure that we're treating every condition that could or needed to be treated, especially since with ADHD, it's a very brain-based disorder. So with that, we know that they respond very well often to medication treatment. A medication naive patient will about 50 to 80% have a good response to the first medication that they try for ADHD. So we definitely want to make sure that they are not falling behind or being excluded in academic settings or other areas where they could be doing better. And then again, the prevalence of having autism in patients with ADHD is a little bit lower, but still between 20 to 50%. So really, I think the takeaway is to really screen for both disorders when you see one. And then in terms of some often overlapping or misdiagnosed conditions, one thing that I often see in the populations that I deal with is that we do have a lot of patients who come in with autism, and the school is complaining of things they call oppositional defiant. Or even at home, the parents may say, he refuses to comply with what I ask him to do, or he only will do it if it's something that he wants to do. And so we need to kind of understand this a little bit better. So with true or, traditionally diagnosed oppositional defiant disorder, this is more kind of a pattern of behavior that presents itself often in relationship to kind of poor frontal lobe functioning, poor executive functioning, and some kind of overlapping environmental factors. And so what we do see that can be similar is that they may lose their temper or become angry or have meltdowns when asked to do certain things that the authority figure is asking them to do. What is a little different in our patients with autism is that we have to understand how their point of view is regarding the situation. So if it's something where they feel like their autonomy is being taken away, that they feel like their choice is being taken away, they often can react. They also have very rigid kind of ways of attending to schedules. So if something in their routine is disrupted, or they have to go to a meeting that they didn't know that they had and someone wasn't able to prepare them for that, then you may see more of that kind of outburst or meltdown occurring. And then it's often, like I said, important to recognize that we want to be as specific about our diagnoses as possible because the treatments can be very different for these things. And another area that is being looked into as a possible diagnostic group that could be added to the new future DSMs is something called pathological demand avoidance. And with this particular diagnosis, it's more commonly associated with autism. And some people may have never heard of this before. It's something that I only was recently hearing about in the last year. And what we know about it is that they often have a very high fight or flight response. So they tend to be in their amygdalas are often overactivated. They have a very high fear response. And this can be often triggered from expectations or demands being placed on them when they weren't anticipating that to be happening. So say, for instance, normally a patient may take their medication right after they finish breakfast and get dressed, but for whatever reason, they need to leave 10 minutes earlier than scheduled, and the parent asks the child to go ahead and take their medicine before they've even eaten. They may completely have a panic attack or a meltdown because this is not the normal schedule for them. They may also have, resistance to doing it. They may flat out refuse. And so in a lot of ways, we're really struggling with how do we approach the patient in the best possible way so as not to have them have these unnecessary fight or flight responses occurring. So you can see this sometimes in classrooms as well. They may refuse to do a certain assignment, even if it's something that is not difficult for them, depending on the way that this was brought to their attention. So again, being aware of how we ask for certain things, trying to allow them a choice if possible. And the avoidance for the particular patient may look like them retreating or hiding. They may make an excuse, or they may have a complete meltdown or a panic attack. This is a good little slide to show just some of the things that are occurring and how we need to kind of associate this particular set of symptoms with the rigidity sometimes of autism and their tendency to become triggered or hyperreactive to certain sets of circumstances, as opposed to something that looks more conduct disordered or oppositional. So in this, they may use social strategies as part of their avoidance. They may resist or avoid the ordinary demands of life. They may have excessive mood swings or impulsivity. They may appear obsessive or sometimes focused on other people. They may be more comfortable in role play or pretend, or they may appear sociable on the surface, but sometimes lacking in that understanding or depth of the social communication. And another area that I found to be commonly occurring with our autistic populations is a disorder known as ARFID. So this is a subset of a feeding or eating disorder known as avoidant or restrictive food intake disorder. In this, patients are more commonly associated with autism. So 12.5% to 33.3% of patients with autism may have an ARFID type of disorder versus 1.98% in the general population. And as we know, with patients who have autism, they have sensory sensitivities. Oftentimes, they are noted very young to have very restrictive preferred foods. Often, they may have 3 or 4 things that they eat as a toddler, and that's all that you can get them to eat. They may even not show a specific drive in terms of wanting to eat in the same way. So you may have to sit them down, remind them to eat, put things in front of them because they won't necessarily have that sort of seeking out for hunger as a heteronormative type of patient may. They may also be seen as being very, very picky. So sometimes very young children may be involved with a nutritionist and a eating specialist to try to help them when they're very young to adapt to different tastes or textures. They may have encouraged them to play with their food. They may put lots of different food in front of them and have them smell, touch, or taste it. Also, when they become a little bit older, having them work on trying to prepare certain foods that they have never had before. It's been shown that in even just a regular child who may not like a particular food, such as broccoli, if they have tried it 10 different times, they may have a change in some of their adaptation of their taste buds to actually prefer a food that they previously did not like. So again, more exposure, more having them use multiple different sensory methods, so touch, taste, smell, preparing different foods may be really helpful. And then there also is kind of another subset of children who are very fearful that they may choke or vomit when they're eating. So this can be kind of an anxiety-related problem that also affects the eating issues. So we usually may medicate this with a anti-anxiety medication such as Vistaril, or we may even use a traditional antidepressant to try to address the underlying anxiety concerns. Some interesting things that I've seen patients doing to try to help themselves when they struggle with ARFID is to have themselves and maybe 1 or 2 other people try new foods with them. So they may have like a little scorecard. So they write out whether or not they enjoyed or did not enjoy the food, give it a 1 through 10 rating. And they may also talk about what the food was like. So for instance, a sweet red bell pepper, they may describe it as earthy or dry. They may say that it was a little bit chewy, but again, giving them the opportunity to really describe what it is that they're engaging with can make it a little bit more fun for them. And if you have like a child who's a bit younger and really interested in competition, they may also have something where, maybe every week they have to try 2 or 3 new foods. Another common co-occurring diagnosis is related to Ehlers-Danlos. This is a syndrome that has to do with overly flexible joints, stretchy skin. It can have relations to connective tissue and vascular tissue. And not every patient who has hypermobility will also have the full Ehlers-Danlos syndrome, but many patients with autism will experience a hypermobility of some kind. And as many of you are aware, often working with occupational therapy and physical therapy is very beneficial, may help them work on their fine and gross motor skills, as well as helping to work on core stability. What is interesting is that the female populations with autism were more likely to have hypermobility compared with their male counterparts with autism. So about 44.7% of females with autism were hypermobile as compared to 21.6% of males. And one kind of quick test, this would not be fully diagnostic in any way, but to kind of check to see if there is any laxity in the joints of your patient, you could have them to take their hand and put it fully down on a table and to take the pinky, which is a little bit more mobile than the other joints, and see if they can move the pinky finger up to 90 degrees or further. So most people, and again, you can kind of test it in yourself, most people might get about a 60% lift. Another way to test is to see if you can take your thumb joint and move it all the way down to touch right here around the wrist. So if those things could touch, or if when they were, say, younger, if they're an adult, if they remember being able to do that as a child, it may be worth investigating a little bit more to see if there is a hypermobility syndrome. Other things that can co-occur with the hypermobility, maybe issues of sensory hypersensitivity, can be some chronic pain, fatigue, motor difficulties, and autonomic dysfunction. And it's also important to be aware of this in patients who may have some type of functional neurological condition. So kind of being aware that sometimes these things may not present straightforward, but kind of looking back and seeing if there are other areas that it may fit more within. So, if they have been having, say, chronic pain in their leg, but they've been taken to various specialists and they cannot find a specific organic reason or a trauma as to what's going on, they may need to look further to see, is there any difficulties with hypermobility? Is there some autism that is occurring? Same thing with patients who may have some gut-related issues. So kind of investigating that further, because these things could be relieved with some other kinds of therapies as well. And genes associated with autism may definitely play a role in the development of hypermobility. A third category that I think has been something that I've seen mostly since I've been working with a lot of inpatients is the occurrence of early onset schizophrenia, meaning the onset of a first break episode before the age of 18, with patients who may have previously been diagnosed with autism when they were younger. So parents who reported autism in their children, this was a strong predictor of sometimes development for psychotic symptoms in that middle childhood window. So oftentimes in the 12 through 15-year-old range. And often there may be developmental abnormalities that were seen prior to the onset of some of this psychotic phenomenon. What is also useful is paying a lot of attention to certain factors like advanced paternal age, schizophrenia or autism within the family, and that knowing the earlier that we have the diagnosis and intervention treatment, the better the response, because patients who do have this type of early onset schizophrenia may have more catatonia or negative symptoms, and this may make their treatment much more difficult, as they may have to try many medications and have a poorer response to medication treatment. Medications that have been approved for use in autism spectrum disorder include both risperidone and aripiprazole. These are often approved for the outbursts and agitation that may be associated with some of the behaviors related to autism. Risperidone has been prescribed for children 5 through 16 for irritability and aggression, and aripiprazole for ages 6 through 17. Now, obviously, these can also be used in some younger age populations, but this would be off-label. We also need to be aware and speaking with families about the risks that we may be presenting for any type of metabolic concerns. So we would ideally have a panel of labs drawn before starting medication to see what their baseline blood glucose and cholesterol are, and then every 6 months after initiating treatment, keeping track of daily weights or check-ins with families when they come in as well. These medications can stimulate appetite and again place them at higher risk for some of these comorbid conditions. And some things that I think are really useful that I have seen used both in patients and families who have children with autism. These can be used both at home with families. I've seen them also used in schools or therapy settings. This one's a particular favorite. It's a sensory swing. It can be suspended from a ceiling, or you can actually bring in one of the hammock chair suspension settings so that it sits on the floor and then has the suspension from above. So children may like to sit in this and swing or spin. They may like to lay across in it. They may sit inside of it and read a book or use their iPad. And sometimes they like to close it all around themselves. But it does provide a lot of stimulation and some extra sensory input for the patients. This one on the left side here is it's a rotating chair. So it actually is good for them to sit in this, and they can again spin or sit sideways. They can lay across it. Sometimes having these extra motor and sensory inputs helps them to focus a bit better. It also can help them work out some of their feelings if they're feeling stressed out or anxious. And I think many people are aware of weighted blankets, but they have some smaller versions that are more portable, such as weighted lap pads that can be taken to and from school or other places where it may be useful. One thing that I've encountered a lot with some of my autism population is that they have a strong need for chewing. So they may bite through clothing, creating holes. They may bite on their fingers or fingernails, causing bleeding. And again, this can be a substitution to try to help them to get that sensory oral input that they need while not damaging themselves or going through lots of clothes to try to keep them from biting holes and everything. So there are some that you can hold, like the one on the left, and there are some that are on lanyards that they can wear around their neck and use whenever they need to. Some of them have different little outcroppings on them so that they feel different, kind of in the mouth for the patient. Another useful technique for helping them to calm down is what's called a sensory brush, and you can use this with a parent, or an older child could use it on themselves. But oftentimes they take this and they slowly brush from the top of their body all the way down to their feet. And then this is a good way for them to often calm down. It gives them that type of proprioceptive input that is very useful. And then I don't know if we want to go over the post-test or ask questions first. Does anybody have any questions?
Yeah, I would say you just have to answer, just questions if anybody has any questions. And then I do have the post test for them to answer as a link. Up, you're on mute, Amy.
Sorry, I was just backing out of that since they're going to do the post test on their own there. Okay. Any questions from anybody, or has anybody seen these types of co-occurring disorders with their patient populations?
I did put this in the chat, but just wondering if anybody had any good ideas of like something that like teens can chew on, or replacements for like biting their nails that are less like noticeable by peers. I have a few kids that could use items but have been like very much teased by peers when they use them, and we haven't found other good things.
So I would say that definitely is probably a concern for them. I have seen some that look more like just little necklaces, some bracelets that are similar. But often I think for my teenagers, I'll usually, if they will allow it, recommend some type of chewy candy or some type of gum that they can have.
Looks like Amazon has some rings as well. So I don't know how big they are, but that may be a little bit less. This is really informational. So I appreciate these ideas to be able to share with our parents, families, patients, all of that. So thank you. This was very good.
Thank you so much. And yeah, I see that also the comment from Leanne. Yes, the pathological demand avoidance, I really do believe strongly it will probably be added to the next DSM, because this is something that we see so much. And I think having a name for it and also giving parents a better understanding of what they can do, because it is really counter to how we normally try or how we would normally feel to react in these circumstances. So the idea is to really be thinking ahead almost all of the time when you can, to give them that feeling that they are having a choice, even if it's a small choice in that matter.
Hi, my name's Dr. Shannon Alexander. I'm a psychologist in the state. I'm also the mother of a child with somewhere between level 2 and level 3 autism and an intellectual disability. And so he's 13. He was diagnosed when he was between 3 and 4. So we've been on this path quite some time. And I really appreciated everything that you had to present here, Dr. Underwood. And I agree that the pathological demand avoidance, I look back and that's been such a prominent part of this whole picture. And, I think we just kind of lumped it all together with autism. That's just part of autism, but it does help, I think, to explain some of it by labeling it, by naming it. So I am hopeful that that will be something that's included in the next DSM. Thank you.
Thank you. Thank you so much for your feedback.
Okay, any other questions? I am going to go ahead and put the post-test and the evaluation link in the chat. I also will be, as I said, sending out an email with the information for you afterwards. So you will be receiving that and with the slides. But really appreciated this, Dr. Underwood. I will say a lot of the sensory things that you went over were things that I used with my child. So definitely beneficial. We used to have something we called the worm. And so my mom had sewn a really long tube out of like swimsuit material. And so it was something that we could hold at one end and she would worm her way through it. And so she loved the worm.
Oh, that's so inventive. That's awesome. Actually, they have something not quite like that, but something called the body sock, which
yes. Yeah, I would say it definitely
really
was pre that. That child is now almost 25 and a nurse for Sanford. So this was definitely a long time ago. But it was learning those different sensory things, So it is always fun of doing those things. But and she definitely chose nursing as a career because it was a career that was very black and white and one that she could, work within. So
that's amazing. That's awesome. I really appreciate you all letting me share something that I feel excited about. And hopefully, like I said, that it was something that people could learn something from, because I didn't want to just do the traditional kind of go through the DSM the whole time. So hopefully this was good for everybody, and I appreciate your time.
No, and I really appreciated I will also say, and for everybody, so thank you for your time. Appreciated going over some of those stats regarding the overlap. I think that sometimes that is missed, that really these are co-occurring conditions. And I often think that the DSM is set up to go towards kind of a single diagnosis, without really this idea that there is overlapping conditions and how that
Right.
affects individuals. So yeah,
And
so
I
thank you
think-
very much. Appreciate it.
Yeah, I do hope to, yes, not just for autism, but for a few other areas too, including kind of the bipolar to schizophrenia spectrum. I do think that we need to also be looking at that. How do things kind of overlap in different ways? What is that spectrum? And hopefully the diagnostics will start to reflect that a little bit more in the future.
So yeah, I definitely hope so as well. So thank you. Appreciate it.
Thank you. Have a good
Okay,
day.
everybody. So thank you very much. If you'd like to join us again for our next echo, will be November 20th, and that will be covering pediatric acquired brain injury. So join us for that one as well if you're interested. And take care, everybody. Appreciate it.